It's not every day that you come across a legitimate expert in three very complex topics and has a niche within a niche in helping her patients deal with these different dynamics all simultaneously. Cancer, menopause, and sexuality. Three things that in them of themselves individually are complex to help patients. Today's guest helps her patients with all three, oftentimes simultaneously as they weave through each other during these different chapters and different phases of one's life. To give you a sense of what today's guest brings to the table as far as expertise goes, she has got her Doctor of Nursing Practice, her DNP. She's a fellow of the American Association of Nurse Practitioners, a fellow of the American Academy of Nursing. She is a Menopause Society certified menopause practitioner and a certified sexuality counselor through the AASECT. She is the clinical director of the Women's Wellness Clinic at the Barbara Ann Karmanos Cancer Institute in Detroit, and she also practices at the Oakland Macomb OBGYN. She lectures at universities across the country, was lead author of the Menopause Society's 2023 non-hormonal position statement, sits on the Federal Advisory Committee on Breast Cancer in Young Women, and her DNP textbook is in its fifth edition used in graduate nursing programs nationwide. Today's guest is an absolute expert. If she's somebody that you're not paying attention to now, by the end of this conversation, I guarantee you will be. We go through a host of different types of angles within her areas of expertise, but this could have been a very long podcast. We kept it down to an hour. We could have gone 3 or 4 hours easily. That being said, I am honored to have had the opportunity to sit down with Dr. Lisa Chism, and I hope that you all enjoy this conversation that we had. Welcome, Dr. Lisa Chism, to the Business of Medicine podcast. Enjoy, everybody. I want to start at in your interesting intersection that you have, because you have a niche within a niche that I don't quite understand, and it's this intersection of menopause, breast health, and breast cancer, and then you also are a counselor in sexuality as well.
Mhm.
And so typically you find, providers that will niche themselves into one, maybe
Mhm.
two, but you have this interesting niche within a niche kind of things. What do you have an elevator pitch? If somebody asks, like, what do you do? What do you tell them?
I tell them that I am passionate about taking care of breast patients, but realize that many patients with either an elevated risk for breast cancer, history of breast cancer, don't have their menopause and sexual health needs met. It's definitely been an unmet need that I pretty much discovered probably about 15, 16 years ago when I started taking care of patients with breast health concerns back at Karmanos Cancer Institute in Detroit. When I really fell in love with taking care of breast patients. Prior to that, I had not taken care of patients with breast concerns. It was brand new. Nurse
Mm,
practitioners, PAs, physicians, we don't really get breast training, we don't get menopause training, and we don't get sexual health training. So if you
mm,
do this kind of work, you really are seeking out the education, the resources, certifications, credentials on your own. And that's
mm,
really what I started to do. I just kind of from the ground up realized that my breast patients weren't having their menopause concerns met. So I turned to the Menopause Society, which used to be the North American Menopause Society, joined the organization and earned the certification through that organization. And then it was very quickly, probably about 2 or 3 years later, I realized this huge overlap between menopause and sexual health. So that's something I'm really passionate about because I don't think women and clinicians generally understand how much menopause can interfere with sexual health. So that led me to University of Michigan where I did their ASECT training, American Association of Sexuality Educators, Counselors and Therapists, and that was about a 3-year long process. It's about a 13-month didactic program and then followed by 30 hours of supervision, and became certified as a sexuality counselor. And that's where I really developed that niche at Karmanos, taking care of women with breast history, even if it was just that they'd had some sort of occurrence or biopsy that turned out to be benign, there still was a lot of fear, or they had elevated risk, and really caring for their menopause and sexual health concerns, and developed a clinic there that really was devoted to that. So, as far as my elevator pitch, I think what it really means is I didn't, where you start may not be where you end up. I mean, I started as a nurse practitioner 30 years ago, really immersed in the gerontological space, but always had a passion for women's health. So my original master's is in gerontological nursing. And then I went back for women's health and did a women's health track, and then envisioned for several years, how can I combine, and ended up with this midlife women's health, also intersecting with breast health, and it kind of led me to my path to where I am today. So I think when I talk to clinicians and they want to know, how did you get from, like you mentioned, this niche, it really was a process of noticing unmet needs and trying to fill that gap and fill my knowledge gap, which is what we're all still trying to do. I just posted a thread not too long ago that said I know more now about menopause care than I did 5 years ago, but I don't know as much as I'm going to know in
Mhm.
5 years. It's just been an amazing journey, especially in the last 2 to 3 years, with how we care for women and approach menopause care. And then right now in the space, really seeing this much more heightened awareness and care to breast patients with any kind of breast health concern, and breast cancer survivors, which I've felt for 15, 16 years as an unmet need. And it's amazing to me to be doing this work now and watching my colleagues develop their awareness and learning from them, as well as gaining my knowledge about, every woman, even with a history of breast cancer, deserves the conversation about what do we do for your menopause and sexual health concerns. And if that means the conversation includes hormone therapy, then that's what the conversation should include.
Mhm.
So it's a long elevator pitch, but it's really more a synopsis that I'll give people about my journey and what led me to where I'm at now.
So, is there a connection, correlation when it comes to breast cancer and menopause? Do you see more circumstances where breast cancer shows up during menopause? Um,
Both.
okay.
So, what happens in menopause with estrogen decline, this can happen for young women who undergo cancer treatment. So, we can cause an abrupt temporary menopause, even for a woman in her 30s, with treatments alone. We can induce menopause as part of treatment. So, basically, stop the ovaries from producing estrogen, testosterone. And that can lead to so many changes, one in particular being vaginal health. So, is the minute we do that, changes to the vagina can occur from the declining estrogen that can lead to pain, decreased lubrication, diminished arousal, diminished or absent orgasm. So, we've got physiologic changes that we can actually cause because we induce menopause, or a woman happens to be menopausal and undergoes treatment. And then when we use, say, an aromatase inhibitor, we're bringing your estrogen levels even further down as part of treatment. So, a side effect can be all of the vaginal changes. So, it can compound these symptoms. And then finally, some women are on hormone therapy and have to come off, at least as we're talking about this more and more in the space, definitely maybe during treatment and maybe for years after, depending on, the whole risk benefit discussion. But we are generally taking women off of hormone therapy. So if they had these changes, now they no longer have the support to stop the changes or treat the changes to the vagina. So that was a huge awareness for me when I realized this overlap. But then there are other factors: body image, losing a body part, losing a breast. Many women experience arousal from nipple stimulation. Some women can achieve orgasm from nipple stimulation. So now we're doing mastectomy and we're taking away a source of arousal. And then also women feeling like their whole self image, who they are, is changing, and they have to adapt to that. Their partners have to be aware and adapt to that. It can change dynamics in relationships. I had a patient once that told me she had bilateral mastectomy and reconstruction, and her partner, thought that he was doing a good thing by coming up behind her and touching her reconstructed breasts. It was his way of showing her, I accept you where you are. I love you how you are. But for her, she wasn't ready, and this felt foreign. These breasts didn't feel like hers. She
Mm,
was still uncomfortable. She wasn't used to them, and she didn't want that to be the center of the room, and especially during intimacy.
mm,
So they were having a real conflict. So it wasn't until I talked with her, and I sometimes do this technique with patients where it's called body mapping in the literature, where you draw a figure of the body and you have the patient draw an X where you don't feel comfortable being touched. What part of your body are you not comfortable having heightened awareness or having your partner touch or pay attention to? So that gave her the power to say to him, you know what, stop touching me there. It's not helping. And he didn't know that. So it
mhm.
was causing all this friction and dynamic in their relationship. So it can be something as intricate and psychosocial as this type of awareness and adaptation to your new body and what this really feels like and the adjustment period and how do we help everyone adjust to this. Women are frequently exhausted either from menopause and the changes that are happening, the lack of sleep, or from treatments. And decreased exhaustion is the number one reason for low desire. Women sometimes are in this role of being a patient or their partner is being a caregiver and shifting to being intimate and being lovers or intimate partners. Your whole self image and self schema has changed, especially during treatment. So there are so many layers to how breast cancer survivorship, breast cancer treatment can impact sexual health, and it intersects with menopause as well.
It's complex.
Mhm.
What you just described is really complex with, I mean, you have the cancer diagnosis, the losing the breast, the implants, and then the relational side. And I mean, that there are so many different layers to that. How do you even approach that? Because there's a lot of psychology there, right? There's fear there. Then you have the relational side of it. So how do you they say to eat an elephant one bite at a time, right? First of all, I
Mhm.
don't know anybody that's ever eaten an elephant, so I couldn't tell you if that's true or not. But like, how do you eat this elephant when you have this many different dynamics and several of them are really, I mean, they're
Yeah,
big deals. How do you
yeah.
address that?
So, first of all, I have to acknowledge the eating the elephant one bite at a time because love this story. My mentor from graduate school, Dr. Morris Magnan, such an impactful mentor in my life. He used to say that to us in doctoral study. You bite one piece of the elephant off at a time. And he passed away a couple of years ago. And I swear I was just thinking about him yesterday, and
Oh,
I
you're
said,
kidding.
"Morris, I miss you so much." And I was thinking about him because somebody asked me he made me promise that I would publish something every year after I graduated, and I was able to do that until last year was the first year I haven't published something, and it's really kinda tugging at me,
Oh,
and it made me think of him, and I was missing him, and it's a sign that you just said
it is
that.
I think
That's
he just
Morris is in
tapped
the
in.
room.
Yeah,
Morris is in the room, yes,
Morris is in the room.
amazing man. So, this answer to your question about how do you unpack this, and especially I have the fortune of having about 30 minutes with patients, but
Okay.
that's a big conversation.
Mhm.
And you're tapping right into how complex and how do you approach that. This is where I can honestly say the constellation of things that I've been through personally and the preparation and training and years that I've spent doing this kind of work really come into the room because the program I went through at U of M, I was with sex therapists or actual mental health therapists. We were all trained together. Now, my certification is as a counselor because I'm a clinician, and theirs was as a sex therapist because they are therapists. But we were together, and I learned from them and spent a lot of time trying to, while nurse practitioners aren't typically trained in the counseling piece, really immersing myself in that piece. The other side that really has helped me is going through trauma personally helped me understand trauma more and drove me to get certified as a trauma informed care practitioner. And that training helped. So when I come in the room, what I bring to that visit when we're starting to unpack how has your cancer treatment or survivorship or wherever you're at, or even just menopause impacted your sexuality, your sexual health, I'm bringing all of this with me and just starting with very open ended questions. I also rely heavily on Rosemary Bassan's model of sexual response, and she speaks a lot about arousal preceding desire and a lot about subjective arousal, like what's making you aroused in your head, not just physically. And when you really start to unpack what's going on with women, and we think about at any given point in their lives how many things, how many hats they're wearing. We talk about if you have financial concern, that's going to be on your mind. If you have children, whether they're young children and they're underfoot and you're in a caregiver mom role, very immersed, or you have adult children who are going through their own issues as they're starting to adult, that's going to be on your mind. You could be taking care of extended family members. A lot of women in midlife are in the sandwich generation. They're caring for parents, they're caring for family members. Your spouse could have a chronic illness. You could have a chronic illness. You have cancer or you're being treated for cancer. You may feel that there's a lack of emotional intimacy. Maybe you feel like roommates. You may feel physical changes, vaginal changes. You're exhausted, joint aches and pains, pain from surgery. And I draw a circle on my whiteboard. I have a whiteboard in both of my clinic rooms, and I draw a circle to illustrate Bassan's model. And we start at the top half of the circle with all of these factors. Then we get finally to arousal, then desire, and then the cycle rounds out with, women deserve pleasure, so ending up with an orgasm. So moving around the cycle, if anything up in the top half that I listed is an issue, women don't put this in a box. So subjective arousal is going to be hindered by all of these other things. So when I do this with women, it organically starts to open up. Well, yeah, that's going on. Well, yeah, I feel that. Well, yeah, that's going on. Well, you're right. I don't feel like a partner, a romantic partner. I feel like I'm my spouse's mom, or I feel like I'm in a mom role, or I'm too busy healing. And it really helps women understand how normal they are that they're experiencing either decreased desire or decreased orgasm or some sort of sexual health concern. It helps them understand that they're not alone, that they're not broken, as the wonderful Dr. Kelly Casperson talks about in her wonderful book, You Are Not Broken. It helps them understand this. And that really starts to organically unpack where are we at, what is really happening in your relationship, or what is going on with you physically that is interfering with desire, interfering with arousal.
What's
Also
your
recognizing trauma. And I have to, now my understanding of trauma and not re-triggering patients, really being sensitive, always asking about a history of abuse, a history of trauma.
yeah. What's your advice to the male in the equation? So you have this circle, you have all these different elements. Women can't put things in compartments the way that men can. Men, we can be aroused at anything, right? And so there's that distinct difference between the two, which can create conflict. And so as you're working through this with women, and we'll take the kind of the extreme complexity of the cancer out of the equation, and we'll say menopause.
Mhm.
And so females going through menopause, and maybe um, there's physiological elements to the equation, and there's vaginal dryness, there's the psychological lack of desire, and then there's environmental elements.
Mhm.
So you're working with these women. Do you work with the male side, the husband, the boyfriend, the other side as well, or what tools do you share with the women? Like, how do you navigate through that component?
So I'm happy to see couples. I have had my patients bring their spouse or partner in, and that happens more often than you'd realize. They actually ask, can they bring their partner? And if they don't, I offer to let women take a picture, or suggest that they take a picture of, because I've had women say to me, can I take a picture of that? So now that's part of what I say when I'm done drawing and we're
Of
done
the
talking.
circle? Okay.
Yep.
Mhm.
Everything that we so I draw on one side. I'll actually draw my diagram of the perineum and the vaginal tissues, and clitoris, urethra, and I'll illustrate for women, this is what's happening as estrogen levels decline, and this is what can result. And then on the other side, I draw Bassan's model, and I'll draw a connection between, as we're talking about arousal and GSM, so look at how much the physical can impact. And then when I'm done, I say, would you like to take a picture? Because I've had so many women say, can I take a picture so I can show my partner? Or can I take a picture so I can look at this later? The light bulb, I've had so many women start to cry, just
Mhm.
their eyes fill with tears because they realize that they're not alone, they're normal, this is what can happen. And then they want to take this home. So I suggest that. I suggest that if they ever want to bring their partner back. And I think for men, the biggest tool is the awareness and the psychoeducation of how different their experience is from a woman's experience. I always start off too by describing to women that back in the 50s, we had Masters and Johnson, were the folks who studied sex and sexual response, and they actually studied female sexual response. And it was a very linear model. It started with arousal, led to orgasm, led to resolution, and that was it. And then Kaplan came along in the 80s and added desire. And that was what we had. And I draw it very stepwise and very linear. And then I draw up a SANS model and I say, not to stereotype or generalize, but what we now understand is this really seems to be more of a male model where it starts with arousal, starts with desire and then arousal and then orgasm and then resolution. Whereas this is what women look like. And it's just that light bulb. And so I have yet to have male partners take offense to that. Instead, it's really like their eyes get wide and it's that awareness that
Mhm.
can be so powerful. And sometimes when I see women, we don't even end up prescribing unless there's vaginal health concerns, prescribing vaginal estrogen or DHEA. But we sometimes for desire don't end up prescribing anything because it was really just that awareness and understanding the different areas that are interfering and how do we work backwards from there. So the tools for male partners, really the number one is the awareness. I don't treat men for sexual health concerns, but I have to say that that would probably be the biggest tool that somebody would step away from to be able to share with their partner.
Yeah, we talked a little bit about, the an online education platform or something that you might consider doing down the road, and that's a perfect example of the type of education that could be provided. Because I don't, you know, I'm trying to envision this thing in my head. I've been married. It'll be 20 years this June that I've been married. Right, we're in our mid 40s. We're both 44. So she's going
Congratulations.
through it. Yeah, thank you, thank you. I don't, I don't have many tools to help her, right? I mean, and so she's working through the whole menopause thing as well, and so I don't think there's enough. There can be too much education out there for both sides of the equation, and so I could see that being super powerful, and it makes total sense why they would get emotional about it too, because
Mhm,
it's the frustration of not having answers, right?
mhm,
And being in this space as long as I have, and with my role with other providers and their practices, and just the number of stories that I've heard of or been in the room for, where it's like they just don't understand what's happening to their body anymore,
mhm,
and it's not responding the same way that it used to, and so there's a lot of question marks that start to formulate, and then it's odd to hear, but it's like they don't recognize their own body, like they don't understand their own body anymore, and they don't.
mhm,
So that knowledge is so powerful, because now there's a sense of empowerment that comes with it as well, so that I can
mhm.
see why that work is so meaningful. What is the difference between, so you said you went through the program for sex counseling, but so what's the difference between a sex counselor and a sex therapist?
That's a great question. So, as a sexual health counselor, I'm clinically able to prescribe if we need to and really help illustrate and dissect with patients where are their clinical issues that what are the clinical issues that I can help address in the moment. It isn't that we can fix this in one visit necessarily, but we can at least try to dial in on, is there something physical? Is there a disease state that we can talk about? Is there something that I can do from a clinician perspective? I'm not a mental health provider and not trained in that way. So a therapist is really there to provide a much more in-depth cognitive behavioral, using mindfulness, using whatever tools are going to help figure out how can we move you through this and not necessarily focus on a disease state or a condition, but really using more mental health strategies, leaning in much heavier to the therapy side. And I'll refer patients to sex therapists. A couple of my triggers that I absolutely think someone should see a sex therapist is if there is a history of trauma, if there's a history of abuse, And if a woman says to me, I've been like this all my life, or this has been a problem all my life, or this has been a problem for 20 years, that's somebody who needs a sex therapist because there may be some things that we can talk about and we can do clinically and that I can share from a psychoeducation perspective. But I think there's going to be much more that is out of my wheelhouse that needs to be addressed.
And so do you guys work hand in hand a lot of times? Is that
Yeah. I have a
okay?
sex therapist in my area that I refer a lot of patients to,
Uh,
and she'll do the same. And then there are also some therapists out in Ann Arbor from U of M from the program that I teach in. I teach the chronic illness weekend through the same program I came out of. So some of the therapists in that setting know me and we'll work together where I'll send patients to them, or they'll have a patient that they identify may have GSM. So they're wanting to have them see a clinician that can treat that because it really does go hand in hand. We can't
mhm.
discount what's happening physically, but we also can't discount where the mental health piece is going to help as well.
So how does someone know if they need a counselor or a therapist or they need hormone replacement therapy? Like if somebody would be listening and wonder, I wonder if I need a sex therapist or a sex counselor or if I should go, how does somebody know what's a good fit for
So
them?
I spoke for NPWH's Menopause Summit recently. I was part of that speaking about complex breast and hormone therapy and what to do. And it was a case based. And in that program, Dr. Kelly Casperson, did the keynote and she talked about testosterone. And I'm going to quote her to answer you. She said, ask patients, what are your goals? And I love that. And I think if we really ask a patient, or a client, what are your goals? What are you really seeking? What's really going on? That can help start to dissect what a patient needs. And that's when somebody comes to see me for a menopause consult, I'm going to ask them the very first thing I'm going to say is, what can I do for you and what is it that is most bothersome to you or what's going on for you? And then that leads to the conversation of every modality we have available to treat, whether it's non hormonal or hormonal. Everybody
Mhm.
gets that whole conversation. And it just organically kind of goes from there. I think what my advice would be if somebody's listening is if you are experiencing symptoms, if you are experiencing decreased desire, if you are experiencing pain with penetration, decreased arousal, diminished orgasm, or you don't know, you don't feel like yourself, which is something that a lot of women, especially in perimenopause, I feel like we'll hear in a lot of my colleagues in the space are starting to coin the phrase, I just don't feel like myself as an actual symptom
Mm.
because it's
Yeah.
something so many of us so commonly hear from women. That is your sign to seek some help. I think whether or not you need the question as to how do you know if it's a sexual health counselor versus a sex therapist, I think it's always safe to start with a clinician to see because it's frequently both and one isn't going to replace the other. However, there are some women where it is all about vaginal health. And if we can improve vaginal health, if we can make sex pleasurable and women can find pleasure in intimacy, again, desire follows. So, not everyone who is seeking help with this is going to need a therapist, but sometimes they will.
Is this an embarrassing subject for women?
It can be. I am in a setting and in a circumstance where women are either being referred to me or they're coming because they found me and they're seeking. In those cases, not as much. They seem ready to have these conversations. I make it a point to screen many of my patients for symptoms of GSM because I think it's not understood, it's not diagnosed enough, it's definitely not treated enough. And it's common. 80% of women who go through menopause transition are going to suffer from these symptoms. And so many are not going to get treatment. So I will ask these questions, but I try to be sensitive and say, are you having any symptoms? Or sometimes, but my question is, many women at this time in their life are you experiencing
Mhm.
this? So that's when they're not seeking. When women are seeking, they're frequently comfortable with the conversations, but something I always teach clinicians when I'm teaching about how to have these conversations, if you talk about sexual health and sexual function in the same way that you talk about high blood pressure, high cholesterol, diabetes, their mammogram results, and you are so matter of fact and you're using appropriate terminology, you're looking them in the eye, and you're comfortable, it may take a minute. They may look down, they may kind of fidget a bit, but the more you normalize that type of conversation, it doesn't take long and they start to relax and they start to understand that it's a very safe space to talk about these things.
What percentage of husbands would be unaware that their spouse was having it wasn't pleasurable for them to have sex? And would you say it's common that it's a topic of discussion is and the wife or female would say this doesn't feel good, or could this be something that the male would be oblivious to?
So are you asking how often do I think partners are not aware of what women are
Hmm.
experiencing?
Yeah.
Very often. They may be aware of pain because women, fortunately, most of the time have enough advocacy, self advocacy, and empowerment to be able to say it hurts. And
Yeah.
I think what many women come to me saying is it's causing a problem in the relationship because I continuously say no and I show no interest. I have no desire, no interest. And when I start to talk with them about why this is, many times it's because it hurts or
Hmm.
because I feel like it's a job, it's a chore. I'm just trying to get through it. And that may be because it's hurting, or it may be because there's zero pleasure, which can be all part of the same sequelae with what's happening in the vaginal tissues because of declining estrogen or from certain treatments. And I should also mention that while we talk a lot about GSM happening in perimenopause and in menopause, there are other conditions that can cause low vaginal estrogen, lactation. So that's something a lot of I'm in an OB practice where patients are referred to me from OBs and they don't realize lactation can cause low arousal in the vagina. Dr. Rachel Rubin once said in one of her reels that she thinks that GSM should actually be renamed low vaginal estrogen because it can be other scenarios, not just menopause. So
Hmm.
that's an awareness that women don't know, partners don't know. Certain medications, oral contraceptives can cause this. So women need to know this can happen at other points in the lifespan and depending on treatments, hormonal treatments. But the percentage of partners that I think don't understand why this is or how complex it is going to be pretty high. And this is disclosure and I don't know if this is TMI, but I was actually having a conversation with my husband. I've been married almost 30 years. Next year will be 30 years for me and I've done this work about 15 years and I was relaying a case with my husband about how I was so excited because I had a patient that I was able to help because she didn't realize that many women need direct clitoral stimulation. Like 80 to 90% of women need clitoral stimulation to achieve arousal and orgasm. And I said this like I rolled it off my tongue, like this is just no secret. This is no big deal. This is well known, right? My
Hmm.
husband looked at me and said, so you mean like most women? So I was
Oh
like,
yeah.
"Yeah, Bruce,
Yeah.
how
Absolutely.
did you not?" And he's like, "Well, I just thought, like some women. I didn't
Hmm.
realize most women." So I thought that was fascinating to me. I'm like, "You're
Yeah.
my husband and you didn't
Yeah.
know this?" And so here we are. Isn't
Yeah.
that something?
Yeah. Yeah. I I don't I don't remember where I heard it, but that most women can't achieve orgasm with penetration alone, that they need external
Yep.
stimulation. So, yeah, that somewhere along the lines I learned that as well. And I think that's a really important thing for the male side to understand, right? Because it's important to us that it's I think for most men, what arouses them is their ability to excite and arouse their female partner, and so I think that's an important element that is known. That way, the male doesn't feel like he is unable to pleasure,
Yep.
his spouse or partner. And but it's such a taboo topic. That's one of the things that y- you know I wish it wasn't as taboo as it is because it's such an important component to relationships, right? And and it's one of those things that it needs more discussion and even amongst couples. I mean, I would be interested on what your advice or your counsel would be to women who they are saying no because it hurts but they're not communicating that, and so the male side is likely interpreting it as something different,
Hmm.
right? And so it's a miscommunication. So what if this is happening quite a bit, but it's also in most cases not being effectively communicated? What is your advice for females to level set with why she's actually saying no.
I mean, I know that so many of us in the space are constantly saying the same thing, speak up. Right
Mhm,
now, what I'm seeing a lot out there in the literature and in social media is if you're a breast cancer survivor, speak up. Quality of life matters. I
mhm,
just posted a thread that said, We saved your life for a reason. Quality matters. So I kind of translate across the board to all women speak up, seek help. And that's why I try to screen, even if someone is
mhm.
coming to me for a breast concern and they happen to be a certain age, and I notice they're not on anything for vaginal health. How is your vaginal health? Like I've mentioned, many women are coming to me for this. So I think it's just on us to constantly try and help women be aware that it doesn't have to be like this. You don't have to have pain. You don't have to have lack of pleasure. And to your point, where many women, or excuse me, many men garner arousal by their partner being aroused, I've had patients tell me that their partner's frustrated because they aren't having any pleasure or they're having difficulty with orgasm because along we talk a lot about pain and dryness, but something women and men don't always understand is with GSM, arousal and orgasm are significantly affected. Vasodilation is affected, and the clitoris is made up of similar tissue as the penile meatus. There has to be
Mhm.
erection. So there has to be vasodilation for there to be erection of these tissues. So women and men don't understand that these changes not only cause pain, but they cause diminished orgasm, diminished arousal, and I have had women seek out help for anorgasmia, which is very difficult to treat if it is outside of the GSM. But frequently, some of the therapies for GSM are going to address arousal and orgasm, and women are able to achieve pleasure again. I think it's on us to just continuously advocate and help women and men be aware of these changes and seek help. And I'm seeing in my practice more and more of the impact of this, self advocacy and the dissemination of the information, even if some of it's misinformation, it is bringing women in, fortunately. Having done this work for 15 years and in the last 2 to 3, really seeing way more women coming in seeking, I think it's just on us to continuously, raise the flag and say, hey, you don't have to feel like this and we can help you.
Is this the kind of thing that's covered under insurance, or would somebody have to private pay?
They seem to be so I'm in a practice that is not concierge. It is third party payer private practice. And we have great billers. And if you have a diagnosis to go with it, yes. So we use the diagnosis. Unfortunately, GSM is not, to my knowledge, on the ICD 10. So it's still vaginal atrophy, but that's the diagnosis: dyspareunia, anorgasmia, vasomotor symptoms, insomnia, mood disturbance. So you're leaning in on symptom to cover a visit as far as diagnosis. So
Mhm.
I, to my knowledge, have not seen an issue with it being covered.
Yeah, I work with clinic. It's interesting. There's one clinic in particular that for about a year I was the acting chief of operations for them, and a lot of sexual health related stuff. And the clinic bought a device from BTL Industries, and it's called the Exion, and it does vaginal rejuvenation. And in fact, they had such a. I brought this out specific for this conversation. Two things that you get a kick out of. Actually, three things I'm looking at. So to give you a sense of the culture at this one clinic. So one of the nurse practitioners, she gave me this little. Could you see it? This little penis
Yeah,
crystal,
I
and
do
it was
see it.
sitting on my desk, and she gave everybody in the clinic one of those, and she picked it out particular to it. And then I come in one other day, and then she's got this little like flingy little micro penis thing. And then just because she's a brat, I don't know what this is about, but I think it's because I used to be a cop. She's got two pigs that are, mount each other. But as you're talking, these things come to mind because it's a matter of making it less taboo and more mainstream in the conversation. But when it comes to when you say to get help, but women aren't really speaking up, they have to have it kind of extracted out of them. I think that comfort that you're talking about in the practice, it really matters, especially when you're talking about vaginal rejuvenation, where it's like that's somewhat of an uncomfortable procedure that happens, right? There has to be trust with the provider. There has to be, you have to feel safe. And so I would love to see more of these kinds of conversations happening in households where women are they're given the tools to be able to tell their partner, "Hey, this is not actually about I'm not attracted to you. I'm not
Mhm.
This is not about not wanting to have sex with you. Yes, there's these other stressors and these other elements that are going on, but there's multiple, and I'm in menopause, right? So women having more tools to be able to have the conversation because us guys, we're pretty dumb when it comes to all this stuff. We don't experience menopause. We get aroused at virtually everything, and we put things in compartments. So the work that you're doing is really really important, and it's good to hear that insurance covers it. Are you able to work with people all over the country? Do they have to be local to you? How accessible are providers like you?
In my practice, I don't do a lot of telehealth because, interestingly, I'm in a large medical building I'm in a comprehensive breast center, so we have full breast imaging. We have mammogram, whole breast ultrasound diagnostic, mammogram, we do same day biopsy. I give all the results, and we're in a whole breast suite. We're actually in a lower level. We don't have great connection to do telehealth. And
Okay.
I have not personally done a lot of telehealth, and I don't know how it would be coming out, like from state to state. And it's a private practice that's, I'm an employee in an employed
Yeah.
situation. But
Yeah.
I do see patients that come from all over. We're north of Detroit, and I have had patients come sometimes a couple hours because trying to find the type of care can be very difficult. Especially like you mentioned, blending between the
Mhm.
breast history, menopause, sexual health, and there's so much overlap for women.
Yeah. What would a female search for to see if there was, these kinds of services in their area, and to know whether a local clinic is the right fit for them or not?
There's a couple ways to find, well, one, to find a certified menopause practitioner, you can go on the Menopause Society website. Anybody can go on the website and you put in your zip code. And then anybody who's certified in your area in menopause will come up. Same for ASECT. You can go on the American Association of Sexuality Educators, Counselors, and Therapists website and put in your zip code, and you can find ASECT therapists and counselors in your area. Social media can be a great avenue. Many of my colleagues do telehealth and are licensed in multiple states and do this kind of work, more on a concierge level. So I think that access is better. It can be overwhelming how to start. A lot of patients see me through word of mouth because once I
Okay.
think right now, what's interesting, what's been happening is there's been patients actually calling the clinic asking if I'll have the conversation about hormone therapy if they're a breast cancer survivor. Because
Yeah.
this is to me the most fascinating intersection that's converging on what I've done for years, what I've been passionate about for years, as well as this heightened awareness and understanding about hormone therapy and this whole willingness for women to have these conversations. So now it's been so timely and fascinating to do this work because I'm pulling together all of my niches and my experience and my education to have very unique conversations that have talk about taboo. It's been
Yeah.
taboo to have a conversation about hormone therapy with a breast cancer survivor. And many of us now in the space that are so passionate about this and have much more awareness about the literature and what we're basing these recommendations on are willing to have the conversation. I'm not saying every woman who's a breast cancer survivor can take hormone therapy. I'm certainly not saying that. I'm saying that every woman deserves a conversation and deserves a risk benefit shared decision making conversation.
Mhm.
So now I'm having word got out that I'll have these conversations, and women are seeking help if they're a survivor to be able to have someone who will listen about what they're going through and really talk through all modalities, risk benefit. So fortunately, word of mouth is powerful.
Yeah, there's been some interesting um, things going on in the peptide space, and um, and so it seems like when it comes to hormones, stem cells, peptides, like we're moving in the right direction, and there's more and more awareness, uh, around that stuff. I had a question around the breast cancer thing. Are you seeing any kind of trending or You look at like testosterone in males. The average testosterone in a male is considerably lower today than it was in past generations. And I don't know what the average levels are, but they're far lower than like what our grandfathers were. And so, you know, some would say it's partly due to environmental with diets and exposures, different things. Are you seeing any kind of trending around the breast cancer side? Are females seeing more or less cases of it, or earlier or later in life?
Unfortunately, younger. The numbers are definitely up for the under 50 population. It used to be, and it still is more prevalent over 50, and age remains a risk factor for breast cancer. However, unfortunately, we are seeing more and more women in their 20s, 30s, definitely 40s being diagnosed, which is so problematic on so many levels. Women, even if you're following most of the guidelines, don't start screening until 40. I feel so passionate about women having a risk assessment starting at age 25. Definitely special populations like African American, Ashkenazi Jewish women being screened way earlier as far as a risk assessment. And then I think that the screening should be provided based on that risk assessment. In other words, if a woman has a higher risk for breast cancer, screening should start sooner, and that is aligned with most of the guidelines. What's frustrating is guidelines are guidelines. They're based on evidence. You still need shared decision making. You still need informed decision making. Patients still have autonomy and advocacy to be able to do what they're comfortable with. But the most recent American College of Physician guideline is now saying starting at age 50. Have a conversation between 40 and 50, but starting at 50, which is significantly backwards. Finally, USPSTF a couple of years ago finally said, okay, start at 40. They were 50. So they now say start at 40, but every other year. Well, most of us who do this work don't agree with every other year, but at least it was a step in the right direction. And now we backslid.
Mm,
So, with regard to your comment about younger women, this is hugely problematic. We know already that African American women are diagnosed much more frequently in the 30s, and they're diagnosed more with triple negative breast cancer, which can be much more aggressive and higher reoccurrence rates, especially in the first 3 to 5 years. So I definitely think that there's environmental factors that cause breast cancer. I don't think we know exactly what causes it, but definitely environmental. Diet. We know that there's a link with alcohol. And I think that the awareness needs to be around having the conversation about your personal risk and then having a conversation about when to start screening and what the appropriate screening is, having conversations about breast density.
yeah, and on that topic, you and Cynthia Thurlow had a really interesting podcast where you really went into the density side of things. Would encourage people to watch that podcast between you and Cynthia Thurlow. Do you have? I had a client in Clear Creek, Michigan, who she invested in a QT imaging, breast imaging machine, and there's debate as to whether or not the mammogram is safe with multiple exposures and whether or not it can potentially cause issues with too many different exposures. And what are your thoughts, especially as the recommendation is younger, and now that could lead to several imagings throughout one's life. Do you recommend a certain pathway that women go to, or do you have any concerns about, too many mammograms or anything along those lines? Where do you stand there?
So, interestingly, you and I spoke earlier about sometimes you have to take a stand, and some folks will agree and some
Hmm.
folks won't. So, here's where I'm going to take a stand. I
Good for
thoroughly
you.
believe in mammogram. I understand the literature well. There is to date absolutely no data to support that mammogram is harmful. The amount of radiation is very small. It's about equivalent to 7 weeks exposure to the outside environment just living. It's about equivalent to a trip across country on a plane, and that's both environmental as well as what's coming from the plane when it comes to
Mm.
radiation. With that being said, mammogram is the only modality that we can see calcifications, asymmetries, or architectural distortions. These are sometimes our earliest warning sign of a breast cancer that you are never going to feel. By the time you feel it, it's probably been there 18 to 22 months. because it has to be
Oh,
about a centimeter and a half, even for a skilled clinician to feel it. So I feel strongly that mammogram remain gold standard. It's the only modality that has the evidence to show a 40% reduction in mortality from breast cancer. And it's because we can find stage 0 breast cancer. 95% cure rate, not coming back, never going to see it again if we find it that early. And we know this. So I feel very comfortable having these conversations with women about mammography and where I stand. As far as other modalities, and like you referenced the podcast with Cynthia, when you are dense, you absolutely should think about other modalities. And that would be either MRI if your risk is greater than 20% or greater, or whole breast ultrasound, QT testing, similar as far as a great test to see denser breast tissue and assess. MRI, going to be gold standard for your patients who are 20% or greater risk because MRI can pick up about 16 to 22 cancers per 1,000 patients who have dense breast tissue and a negative mammogram. Whole breast ultrasound, about 1 to 3 cancers per 1,000 patients. So the sensitivity is better. However, I feel strongly that a woman make a decision based on what they're comfortable with. There's no radiation with an MRI or ultrasound, but make a decision with what they're comfortable with. As far as supplemental imaging, what I care about is that they have supplemental imaging if they're dense. So that's my stance on mammogram.
good, good. Yeah, take a stance. And as as I told you, that's it's really important that when you're educated in something in particular, that stance be taken, right?
Yeah.
Because it's a pretty conclusive, place that you just took people to that may have been under the misconception or misinformation around
Mhm.
mammogram. So I think that's great. We probably should start wrapping up because it's getting a little bit long. But I'm curious about where you're going, like what your goals are as you look ahead. Where do you see yourself in a few years? What are you hoping to achieve?
I want to practice. I don't 'cause I just turned 58. I got at least another 10 years of practicing in me, and I think maybe in my 60s, depending if I get fortunate enough to have grandkids, maybe 3 days a week and help out my daughter, but I definitely will never leave clinical practice as long as I'm able to. I think that I would love to continue to educate. I've always informally educated, whether it's guest lecturing, formally lecturing, and lately really trying to make an effort in the social media space to share information because I understand even as what am I, a Gen Xer, right? I understand that this is where the information is being shared and disseminated, and it's bringing patients to me, which is great. Even if there's misinformation, if it brings a patient in, that gives us the opportunity to
Mhm.
correct the misinformation. And I never shame patients for getting their information wherever they get it because that's important. That's going to bring them in. So I want a bigger platform being able to share the information that is so valuable that in my mind is going to improve care because it's going to help that patient know, like you asked earlier, how does a patient know they need help?
Mhm.
They don't know unless they hear that they need help or that there is
Mhm.
help. They're not going to know. So I'd like to share more information probably in that space, but I'd also like to continue to formally lecture, educate, publish, kind of what I've been doing, but probably getting a lot more comfortable in the social media space so that I can have that opportunity to get in front of more people to share information.
And I hope you do too, because I think that you have an obligation to. I think, unfortunately, there is so much information that's out there, and it's some of it is being shared by people who are far less qualified. And it is a good thing if somebody, even if they're misinformed, they can be properly informed when they get in front of you. But the ones I worry about are the ones that are misinformed and they make decisions accordingly. Even if we just take the cancer survivor and hearing from somebody that hormone replacement therapy is off the table for them. And, I worry about the ones that choose the wrong path because they're misinformed. So I think there's an obligation for people like you who have the background, the credentials, experience to get comfortable with social media and to get on more stages and to really just broadcast as far as you possibly can. And then on the flip side, I think there's an obligation for people who are not qualified to stop sharing information that they're not qualified to share because it confuses the market where it's it's people's health we're talking about. It's people's lives we're talking about. And so while I love everybody who's passionate about health, I think that we see too often people stepping outside their lane, and it confuses others. And that part to me is unfortunate and scary. So please do get
It's
more
a valid
comfortable with the
concern.
social. Yeah.
Yeah,
Yeah.
I'd like to develop a course too. I'm talking with a colleague about she has an amazing platform, Dr. Jackie Piazza. I mentioned her earlier. She
Hmm.
does a clinician mentorship in the menopause space that I've actually taken her course. It was amazing. And so we're talking about what could I do in the breast space because
Yeah.
like I mentioned earlier, we don't get educated in breast, menopause, sexual health, and breast health, basic breast 101. I didn't know it. People taught
Hmm.
me and that there's probably an unmet need in helping clinicians understand just basic breast health
Yeah.
and interpreting a mammogram result. What does it mean to have dense breast tissue? What modalities are available? What's the data behind each modality? So I would like to also have an opportunity to reach more clinicians and educate more clinicians too in that way.
That would be fantastic. I think that would be great. And make sure that some of that content is geared towards us guys as well, on how we can. I feel and we could go on to like a totally different podcast on this thing, but just how unprepared like I was as a husband that was having a wife going into perimenopause and menopause, um, and like what I can do, what I can't do, how I can help myself, how I can help her. So I think there's also a real lack of education for the other side um, that it goes right along with their wife or female partner don't really have the tools to. So hopefully as you build out that education and you work with your colleagues on that don't forget about us guys, that we need help in it too, largely in how we can help our spouse whatever we can, but then also ourselves not get into ourselves into trouble, by doing things that the
Yeah, that's a
agitations
really
and
good
the
point.
things that
Yeah.
happen. Yeah, I've gotten myself into trouble just not even not knowing what, like, that I was stepping onto the battlefield at
Hmm.
times, right? But this has been really fun. It's been really interesting, man. We could go so many different directions with this, but this has been really fun and eye-opening. I'd like to do another part 2 of this, drilling even further down in the sexual health side of things. That's a fascinating topic that a lot of couples that
Hmm.
is problematic, and the different sciences and things that are happening around being able to help. I know you don't work with men and erectile dysfunction, sexual health and things,
Hmm.
but just the whole dynamic. So that'll be a fun separate conversation.
Love to.
Where do people find you? I know you're up in your social media game, but where do people go to find you?
Finding me practice location
Well,
or
that too. But you
for
have a book
social.
that came out not long ago. Social media.
Yeah, so I have 2 platforms. I have the Dr. Mommy Poppins is my Instagram, and everything I do on Instagram goes to Facebook, and I'm just under my name in Facebook, and then I have the adopted nurse is my other, and I'm also passionate about adoptee advocacy. This is a space where when I think about risk for breast cancer and we think about cancer risk in general and screening, so many of our guidelines are around family history. Adoptees don't know their family history. So
Mhm.
that's something else I feel very passionate about. The second book I wrote was actually a memoir on my journey really through my whole life as an adoptee and how different directions and different traumatic events and healing impacted me and kind of brought me to where I am here as a professional, as a woman, as a daughter, as a mother, as a friend, as a wife. So it's kind of my whole story, but it kind of highlights my passion about the adopted community and the whole constellation, between birth parents, adoptive parents, and adoptees. And it's a very complex constellation. And when you intersect that with healthcare and seeking healthcare as a healthcare provider, kind of diving into a lot of the different nuances around caring for adoptees, it just amazes me how many times I will be doing a risk assessment and I'll say to a woman, family history, and she'll look at me and say, I'm adopted. I don't know. And I'll
Yeah.
smile and I'll go, yeah, like it's like a sisterhood almost. Like I understand. I know what
Mhm.
that's like. And then also the whole journey of finding birth family, which I've lived and survived.
Wow.
On one hand, very positive. My mother's side, my birth mother's side, amazing. My birth father's side, lots of trauma that I've survived. So once you know, you can't unknow. And then when I talk to women about getting genetic testing, it's that same conversation. That's a very personal decision. If you find out you have a mutation, you can't unknow. It's that
Mhm.
same parallel. So there's just so many fascinating ways that my whole journey has intersected. You can't take out who I am as a healthcare professional from who I am as a person.
Yeah.
And
Yeah.
my adoption journey impacted that as well. So I kind of tell that story too in my memoir.
I think it's awesome. There's people that they define their present and their future based on the past, right? And then there's others that define their past based on their present. And the difference there is whether you decide to take whatever the trauma and the past circumstances and make them a superpower or a crutch. And what's really cool about you is that you obviously have a a story, and a story that you've walked a journey that most people haven't. A few people can relate to it, but you've clearly taken it and found your superpowers within it, and you clearly live every day with passion and for what you do and who you help, and so I think that that's a really cool thing and something that others are searching for. And so it's always good when you have people that have have gone through a lot of trauma and experiences and things, and they let their present define their past and they turn them
Mhm.
into superpowers. So good for you
Oh,
for
for
doing that.
sure. Absolutely. I 100% feel that throughout my whole life, how do you flip the script? How do you take
Mhm.
that experience and grow from it, learn from it, but rise above it? And I teach my daughter this even, she's about to be 26 years old. Don't ever take no. And if a door closes, there's going to be a workaround. If you
For
want it bad
sure.
enough, you're going to work around it. You're going
Yeah.
to find a way. So many doors that closed on me.
Yeah.
So many, so
Yeah.
many. And then you find that workaround. You just look at that door and you go, you know what? Not today. I'm going to figure this out. I may not know right now what this looks like,
Mhm.
but I'm going to figure
Mhm.
this out.
Yeah.
But yeah,
Yeah.
for sure. I love
That's
that.
a great mindset. Yeah. Yeah, it's a great
Yeah.
mindset. Well, Dr. Mommy Poppins, Lisa Chisholm, this has been really fun and all kinds
Yes.
of gold
Ditto.
nuggets all throughout it. So thank you again so much for coming on
Thank you.
and look forward to the next one. I'm sure we'll do another one.
Oh, I'd love that. Thank you so much. Thank you for the opportunity. Thanks for talking with me.
Yeah, you're welcome. All right, bye bye everybody.